Good afternoon / evening, everyone. This is Gail, aka Sunshine, here with another episode of the Beyond Cancer series. I believe we're on number 25, and today is fertility and cancer. In case you're new, let me just tell you a little bit about EVIG experience. EVIG started in 2012 was started by Nancy Farrow after her oldest son was diagnosed with cancer and then kind of had a hard time getting his life back on track. The goal is to provide physical and emotional and bonding experience for cancer survivors to help them live beyond cancer. We've been doing this, I think we have now about 500 campers and alumni, and this series is put on by a group of us alumni who really wanted to help keep the sense of community going. So we've been putting on this series. It used to be less often with COVID. It's become bi-weekly now, but we've covered a lot of different topics related to survivorship and living beyond cancer. So today's episode, I'm really excited. We have Dr. Kondapalli with us, and she is a fertility expert, and she's going to be sharing with us some things about cancer and fertility. So Dr. Kondapalli, thank you so much for joining us. It's so good to have you.
Thank you for inviting me. I'm thrilled about being with everyone this afternoon.
Awesome. Well, let's start off, if you don't mind. I'm just going to let you tell us a little bit about yourself, how long you've been doing this,
Sure.
Where you're from, one fun fact, whatever you feel like sharing with us.
Well, cancer and fertility is really my passion, and it really developed when I was a resident. I did my training in Chicago, and then I did a fellowship in Philadelphia before I came out to Colorado. I've been in Denver since I finished my fellowship in 2011, and I was really recruited to Colorado because of my expertise in oncofertility, which is fertility in cancer patients. I've been at my current position at the Colorado Center for Reproductive Medicines since 2014, and I see almost all of the cancer patients within our practice here. I grew up in Cleveland, Ohio. A fun fact about me is in the spirit of our recent Halloween holiday, My favorite candy are Reese's Easter eggs.
Wonderful. Excellent. I love it. Thank you so much. Well, let's dive in. And if you're watching today and you have questions, please put them in the comment section and we will throw them up there and we will ask Dr. Kondapalli as we go. Okay. So first, let's start off. We're talking about fertility and cancer. So what options are out there for preservation in terms of fertility?
Great question. I meet a lot of young cancer patients at the time of their diagnosis. It can be an overwhelming experience because they're kind of hit in the face with this diagnosis and thinking about starting a family, and even, their ability to have a family in the future may just, it just seems so overwhelming. So I see a lot of patients in thinking about future fertility. The options that I can provide to patients for men and boys that have gone through puberty, the mainstay of fertility preservation is really sperm banking. So that's a process where men or postpubertal boys can produce a sperm sample, and that sperm can be frozen. Once the sperm is frozen, it actually stays frozen and healthy, indefinitely. There's really no shelf life on frozen sperm, and the viability a year from now will be the same on the viability a decade from now. So that's the mainstay, and pretty simple for men to come in and produce sperm sample and freeze. For women, it's a little bit more complex. The two main fertility preservation treatment options that we have for women, one is called egg freezing. So we can have women go through some hormone treatments, and we can do a surgical procedure where we can collect or harvest eggs from the ovary, and those unfertilized eggs can be frozen in time. If a woman has a partner or is willing to use a potential sperm donor, we can fertilize the eggs and create embryos and freeze. Both of them are great options, and each one has its pros and cons. And for a particular patient, I can review with them what might be a good fit for them. There's another option that used to be considered experimental, where you can actually freeze a portion of the ovary. So all of the
Interesting.
eggs in the ovary are actually on the surface of the ovary. The ovary, if you can imagine, almost looks like a walnut, and the surface is called the cortex, and we have thousands of eggs on the surface of the ovary. The depth of the surface is only a couple of millimeters. So you can almost imagine if it's like the skin of a grape, all of those eggs are on the outside surface of the ovary, so that you can actually remove the top layer of the ovary and freeze that. That's called ovarian tissue freezing. It used to be considered experimental. It's no longer. It's standard of care. That tissue can be frozen. Then a woman, once she's gone through her treatment and is in the survivorship phase, we can actually have her come back, and that tissue almost serves as a tissue graft. It can actually be transplanted back into the body, and then a woman can achieve a pregnancy. Now, typically, we will still need to do some assisted reproduction, even if we put it back into the pelvis, but that's an alternative option for some women.
So you're saying if both ovaries were removed?
Actually, you don't even have to remove the entire ovary. So you can actually just remove the outer layer of the ovary. On a centimeter of tissue, there's hundreds of eggs that are in such a small space. So I do have some women where we don't even have to remove an entire ovary or entire surface. We can remove half of it or a third of it and just freeze that. So the technology has really advanced remarkably over the past, decade to 2 decades. And one of the things that makes my field so exciting and why I decided to go into reproductive medicine is that if you think about in vitro fertilization, IVF, which is a process of fertilizing eggs outside the body, IVF was originally started about 42 years ago. So it has not been around for that long. So the amount of advancement that's occurred in my field over the past 4 decades is mind-blowing.
I mean, it's amazing to me. So basically what you're saying, if they don't remove the whole ovary, do they take that skin, so to speak, and put it back on? I mean,
absolutely.
That's incredible.
It's pretty amazing. So there's a surgical technique that we can take that tissue after it's been frozen. You can actually revive it by essentially thawing it. So we take it out of the freezer and kind of wake up that tissue. And then we create a little tissue graft that then can be essentially transposed on the old ovary.
Incredible. So for all of those, for both the sperm banking and the options, what are the risks involved? What are the chances of success and all of those kind of things?
That's a great question. So sperm banking, the risks, are very minimal. A man or a adolescent boy would need to be able to produce a sperm sample. So, and that's usually an ejaculated sperm sample. If a gentleman is not able to do that, there are some other procedures where we can actually surgically aspirate sperm with very minimal anesthesia or even local anesthesia. That would be an alternative option. With frozen sperm, the 2 different options, if a patient decided to use that sperm in the future, we can actually thaw that sperm and use it for a technique called intrauterine insemination, or IUI. That's where we can thaw the sperm and then we can place it into the uterus through a little straw. The other, through a catheter or a straw. And then we can allow for natural pregnancy to occur in the fallopian tube. The other option would be in vitro fertilization or IVF, where we can fertilize the eggs outside of the body in a petri dish. Chances of pregnancy or success really depends on how healthy the sperm is. And one thing to keep in mind for a lot of cancer patients is that, particularly for men who are very sick at the time of their diagnosis, it's not uncommon for the sperm count to be affected. What I've seen is that when I've had some young cancer patients, they've been particularly sick, they have pretty aggressive cancer. When they do produce a sperm sample, it is possible that the sperm count is very, very low or even 0.
Wow.
because the testes are really sensitive to what's happening in the rest of the body.
Yeah.
So when men are fighting off an infection, fighting off, malignant or tumor cells in the body, there are signals that are sent to the testicle that says, hey, sperm production, not the priority.
Right.
Let's like roll it back here. And so we do sometimes see that the sperm count is quite low or zero.
Wow.
Even if the sperm count is low, we will freeze any sample that we obtain. That sample could be used for something like IVF in the future. And so part of the success rates for the frozen sperm will depend on how old the eggs are and how old the woman is.
Oh, really? Not so much the sperm, but actually the age of the eggs. Interesting.
Exactly. So one of the big differences between guys and girls is that boys start making sperm when they go through puberty, and men can make sperm well into their 70s or 80s.
Right.
Alternatively, girls are born with a finite number of eggs, and over our lifetime, we lose them. And as women age, the number of eggs declines, but also their eggs age, unfortunately.
Wow.
So the older a woman is when we're trying to use this frozen sperm, let's say her partner went through cancer treatment but was able to freeze sperm, I would be counseling her that her probability of success is also based on her age.
Interesting. So the sperm itself, when it's frozen, doesn't lose its potency, so to speak.
It does not.
Whereas the woman, the egg.
Yeah. Now, but the other thing to keep in mind is that that's true if I had a female cancer patient who froze her eggs or created embryos. The eggs and embryos are frozen in time. So even as she ages, the uterus doesn't age really until women approach their mid-40s. So if I had a young cancer patient who, let's say, for example, froze her eggs at age 26, but she waited until she was 36 years old to use those eggs, her uterus is not of concern to me as long as it's nice and healthy. And I'm feeling fairly optimistic because I have 26-year-old eggs that have been frozen in time.
Right. Interesting. So in terms of success, I guess the definition of success in this case would be pregnancy, right? I mean, that's the ultimate goal.
Exactly.
So of all of those things, freezing the sperm, freezing the eggs, freezing the embryos, the main factor, if I'm hearing you correctly, is the age of the eggs. I mean, obviously anything can happen, but.
Correct. That is absolutely right. So for women, the biggest factor associated with our fertility, our ability to get pregnant either naturally, our ability to be successful with assisted reproduction, the number one factor is age, at which time you're going through treatment.
Right.
Now, one other thing is that sometimes women will ask me, is it better to freeze eggs or freeze embryos? And really the difference is the viability in the future when you go to thaw them. And so that how good the freezing and thawing techniques are is really dependent on where you choose to do treatment. So this is one thing for the audience to really keep in mind. If this is something that's on your mind and it's something that you want to pursue, really doing your homework and taking a look at different fertility clinics that are in your local area is really important. So there's some good resources for folks to look at to compare fertility clinics, because the overall success is really dependent on who's the person that's freezing my eggs and who's the person that's thawing them.
Interesting. So it really has nothing to do with whether it's the embryo or the egg.
Yeah. Now the viability, correct. Now the viability is slightly different. Now, in my practice at CCRM, we were one of the first IVF clinics in the world to successfully freeze and thaw eggs. So we've been doing it since 2007. In our hands, about 95% of eggs that we freeze will be viable in the future when I go to thaw them.
What was the percentage?
95%.
Wow.
Yeah, almost all of them.
That is high, yeah.
Very, very high. In contrast, our survival rate for frozen embryos is nearly 100%. It's about 99%.
Wow.
And the big difference is that an egg has one single cell versus an embryo that has about 100 cells. So it's a much more robust structure. So that's why the viability is a little bit higher. So I think if the audience members are looking into some of these these options, doing your homework and really asking questions about how long have they been freezing eggs or embryos, what's their success in thawing the eggs or embryos. Most other IVF clinics or fertility clinics started freezing eggs in 2012. And so folks that have frozen their eggs, especially if you go to a practice or a clinic that doesn't have a lot of experience, they may not have had anyone come back to use their eggs. So they don't even know.
Gosh, I mean, I'm curious, this is pure curiosity. How long is the process of thawing? I mean, how long does that actually even take?
Yeah, so it's a bit of a misnomer, even though we call it thawing. When we freeze and thaw eggs or embryos, the freezing process causes the eggs or embryos to shrink because you're dehydrating the structure. So you're taking out all of the water from that structure and doing a technique called flash freezing, or vitrification is the fancy word for it. It's essentially plunging that egg or embryo into liquid nitrogen and it flash freezes it. And that's the technique that has really revolutionized our success with thawing eggs and embryos. The thawing process is just rehydrating the egg or the embryo. So you're reintroducing hydration or water into that structure over the course of about 20 to 30 minutes. So freezing is flash freezing, and the thawing process usually takes about 20 or 30 minutes. These things, eggs and embryos and sperm are very, very resilient. And one thing to keep in mind is that there's really no shelf life on these. They don't get freezer burn. So the longer you keep them frozen doesn't mean that they're not going to be viable 20 years from now. They really are frozen in time.
That's incredible. So I'm sure there are many people who are watching and wondering, okay, this can't be cheap. What does insurance cover? Are there certain procedures they do cover and certain ones they don't? How is that?
I think that's such a complicated question. I think medical insurance, especially for some of the folks that are watching today, just navigating the medical insurance questions, even with their cancer treatment, probably has been a difficult do. And if you can imagine, the fertility side can be challenging as well. It all depends on what kind of insurance a person has. So there are some insurance plans that do have fertility coverage. So the specific insurance plan and, talking to your insurance provider, or if you have insurance through your employer, talking to your HR department and getting, an idea of what insurance may cover is one place to start. The other thing that affects insurance coverage is where a person lives. There are now 18 states in the US where there are mandates by their state government that does provide insurance coverage for various aspects of fertility treatment. I'm really excited to be in Colorado because the state of Colorado became the 18th state in the country that has a mandate for insurance coverage for fertility treatment that includes fertility preservation and for patients who have gone through treatment are now facing infertility issues. So checking with your state to see if it is one of the mandated areas. We have a bill that was passed and signed into law in the state of Colorado as of April 2020. It goes into effect on January 1st, 2022. So Colorado residents, if they have a private insurance plan that has this as a benefit, they are mandated to cover fertility services. So checking in with your state. And going and just looking online to see, does my state cover fertility benefits? Would be another great place to start.
And is there a difference if it's fertility, like someone's having trouble getting pregnant just for whatever reason, or if that's specifically related to cancer treatment and cancer? Is there a difference in coverage? Are there questions that should be asked along that lines. Okay.
Yes. So I think a good starting point would be, if you are seeking a consultation or trying to get some information and you meet with a fertility specialist like myself, they can be a friend to you and they can be an advocate. So I have in my own practice and experience, I have had, I've appealed to medical insurances and said that there was a medical necessity for why a patient needed to pursue fertility treatments, based on their cancer treatment and based on our knowledge of infertility risks, making an appeal to the medical insurance and saying that this is a person who's at high risk of infertility due to something that was out of their control because they're receiving other medications that will have this long stream or downstream effect. And so we've been able to, for a handful of patients, get medical coverage for it because we say that it's a medical necessity. So I think talking to a fertility specialist and, using them as your advocate can be helpful. And it's just a series of steps that a physician will need to go through. It oftentimes starts with a letter of medical necessity, and then it oftentimes it goes down the path of discussing it with the insurance company and things like that. I think it's worthwhile trying.
Definitely.
And sometimes we can sway the insurance companies to have coverage for that. Yeah.
That's awesome. We have a couple questions. So actually we have a comment that just says, thank you for joining us. Thank you for your knowledge and your passion.
Awesome.
And then we have a question. Would you mind sharing what are the best first steps to get, there's the question right there, to get fertility checked as a woman? I'm approaching 8 years out of treatment.
Great question. So a good first step would be, for a woman, you could talk to your gynecologist or your primary care physician and say, hey, is there a way that I can see where my fertility stands, or really, how many eggs do I have? Now, if they don't feel comfortable kind of knowing what test to order, then you would seek someone like myself. I'm a reproductive endocrinologist and infertility specialist. So my training path is, after I went to medical school, I did a residency in obstetrics and gynecology, and then I went and did a fellowship in reproductive endocrinology. And during my fellowship and residency, I developed this expertise in oncofertility. So you could also go straight to a fertility specialist. And for women, the testing that we would do is to get a sense of what's known as the ovarian reserve. So we talked about how women are born with all the eggs that they'll ever have. That's known as the ovarian reserve. How many eggs do you have at any given time? And the way that we can test that is by doing some hormone testing, which are blood tests. Those are timed with a menstrual cycle. So the first day of a bright red bleeding or menstrual flow is always considered cycle day 1. So a common question that I get is, how do I even know when my period starts? Well, when you notice, because sometimes women will have some spotting and then they'll have a period. So first day of full bright red bleeding is cycle day 1. And there are some hormones. One of them is called FSH. There's another hormone called LH. Those are 2 hormones that are released by our brain, and there's a special place in our brain called the pituitary that releases those hormones. Those are the hormones that essentially talk to our ovaries, get the eggs to grow, get us to ovulate. The ovary makes a hormone called estradiol and a hormone called anti-Müllerian hormone, or AMH. So if I test those 4 hormones, essentially I can see how our brain and ovary work together. Indirectly, it tells me about egg number. Now, it's not going to tell me, I think Amanda asked this question, it's not going to tell me that a woman has 200,000 eggs, but it will tell me, are these numbers in the range that I would expect for your age? Because we said that over our lifetime we lose eggs. So an average number for someone who is 22 years old is not what I would expect for someone who's 32 or 42.
Right.
It always has to be in context of age. The other thing that we can do is an ultrasound. Take a look at the ovaries. Eggs are microscopic, so you can't see them with the human eye, but eggs are in little structures in our ovaries known as follicles. Those follicles look like bubbles. So we just count up how many follicles I see at any given month, and it's going to give me another piece of information regarding egg count. So those are a good starting point for women survivors who want to know where am I?
Yeah.
What are my numbers?
A similar question. After treatment, is there let's say the woman has either, in this case, not necessarily had to preserve her eggs, but is there a safe time that should pass before a woman gets pregnant or tries to become pregnant?
Yeah.
Whether it's actually reinserting or however it happens.
Yeah. So when I get asked that question, the information or that guidance is going to be based on three different things. Number one is going to be having a conversation with your oncologist, because your oncologist is really going to know the horizon or the progression or the risk profile in terms of risk of recurrence, what that interval looks like for any given types of cancer. Even though I take care of a lot of cancer patients, I'm a reproductive endocrinologist, but I'm not an oncologist.
Right.
So I don't know all the specifics on the cancer side. So I tell patients, let's have a conversation about this. Let's get the input from your oncologist, because they're really the expert on the cancer side. They'll give you advice about what they recommend as a good interval of time to wait before trying to start a family. I'll have input based on, fertility testing. If you were able to do fertility preservation, what would that look like? And then the third component, and an important component in this conversation, there are specialists known as maternal fetal medicine specialists. These are obstetricians that specialize in women with a whole host of medical issues in thinking about how we can move forward with a safe and healthy pregnancy. So an MFM doctor is someone that I work really closely with. They're called perinatologists as well. And I have a great group of doctors that have so much experience in taking care of my cancer survivors. So all of my cancer survivors, when they come back to see me, whether they were able to pursue fertility preservation or now they are thinking about fertility testing and treatment, I have them see a maternal fetal medicine provider for some preconception counseling, because as a fertility specialist, most times I can get people pregnant, but I want to ensure a safe and healthy pregnancy. Getting the input from the MFM doctor will provide that for us. So it's the three components: oncologist, MFM, and myself.
That's awesome. Now, one other question that someone had was, if someone's gone through treatment and now they're not fertile, what are their options?
Yeah. So what I talk to survivors about is that there's so many ways of making a family, and we want to come up with the best way of you achieving your dream. And sometimes that's using your eggs and sperm, and sometimes if that's just not possible, there are so many other options. So when I have male survivors who are azoospermic, meaning that they've gone through treatment and their testicles are not producing sperm anymore, the options that we can talk about are using a sperm donor. And that could be either a known sperm donor. So sometimes I do have patients who feel like they want to have some, biological or genetic component to a future pregnancy. So it could be a brother, a male cousin, someone else in the family that could be a sperm donor for them. There's also anonymous sperm donation. So there are sperm banks that I will refer patients to, and we can use anonymous sperm donation for either intrauterine insemination or in vitro fertilization. And then there's also a great option is adoption for men as well. For women, if they go through infertility and they go through premature menopause and being able to use their eggs is not possible, there are egg donation that could be known or anonymous. And if a woman is deemed unsafe to carry a pregnancy and maybe it's just not safe for her, we're concerned because perhaps she's had pelvic radiation. And we know in that setting, the uterus just may not have enough blood flow to hold the pregnancy safely. And she may require a surrogate or a gestational carrier for someone else to be able to carry a pregnancy for her. And then adoption is also a great option reproduction as
Right.
well. So lots of different options that are available
Right.
if a patient is infertile after they go through treatment.
Right. Wow. If you're watching and you have questions, please put them in the comments and we will have Dr. Kondapalli answer them. I think I skipped one about, in terms of getting pregnant, this was kind of the second part of that question that I forgot. Is there, and this may be, like you said, there are 3 components, and this may be where the oncologist comes in. Is there a certain amount of time given having radiation or given having chemo? Does it depend on which kind? Does it depend on how many? And I'm guessing that's an oncologist question.
Yeah, it is. But yes, so it will depend a little bit on what types of chemotherapeutic agents are used for treatment. If it is radiation, what was the site of the radiation? What do we think is the lateral spread of radiation to other reproductive organs, whether it's the uterus, the ovaries, the testes? And so it will depend a little bit about, it will depend on what treatment was given and what the cumulative dose is. But to piggyback off of that question, another question that patients will ask me is, if I'm interested in a fertility assessment, what interval of time should I wait to do the testing? And so many times I use for men, it would be too early to do a fertility assessment, which would be a semen analysis. So men produce a sperm sample and we can see how many sperm are present, what the movement of the sperm is, and we can get a sense of how healthy the sperm is by looking at the sperm under a microscope. That's called a semen analysis. I tell men it would be too early to do a sperm test within 6 months of their cancer treatment. That is the normal window of time in which recovery will occur. And so I don't want to cause unnecessary stress, anxiety. If we do a semen analysis, a month after finishing chemotherapy, it is very likely that there will be 0 sperm. For men, what happens is many times chemotherapy, once it's initiated, the sperm count does become 0. And it usually takes at least 3 to 4 months before we would see some sperm production. And that's because for men, there are stem cells within the testes that will constantly reproduce sperm. But with the introduction of chemotherapy or radiation, those stem cells kind of shut down, and then it takes a little bit of time to kind of wake them up. And in fact, it takes about 72 days to get from a stem cell to a mature sperm that would even be present in an ejaculate. So I advise men, I wouldn't recommend doing a semen analysis before 6 months, and even up to 12 months is still considered the normal range of recovery. If the man hasn't recovered his sperm production after a year of completion of treatment, then I'm much more concerned about a permanent infertility issue. For women, it's waiting at least 6 months before I would do the hormone testing and the ultrasound.
Okay. Very helpful. Thank you. Let's see. We have another question. If your cycle is lighter or shorter post-treatment, is that an indicator that a woman is now infertile?
Thank you for that question. There was a really important medical study that came out, now it's been about 8 years or so, that really debunked this myth that return of menses or changes in a menstrual cycle, having longer periods, shorter periods, correlates to underlying infertility. And it doesn't. So what I would recommend is that if you're concerned about your fertility status, I would recommend seeking a fertility specialist to do the hormone testing and an ultrasound, because menstrual cycles and whether they return or they don't return is a very poor indicator of underlying fertility status. So I'm not worried. And there are times, if a woman doesn't get her period after she finishes chemotherapy or radiation, it doesn't make me worry that she's infertile. On the flip side, if a woman gets regular menstrual cycles, it doesn't give me reassurance that she's
But
fertile.
she is, yeah.
Correct. And that's why we have these objective markers like blood work, the hormones we talked about, and the ultrasound that will give you a much better and much clearer perspective.
Excellent. All right. Regarding sperm count, what are the common myths about what can lower a guy's sperm count?
So, there's, I think, lots of myths out there. But a couple of things that we know are not myths, but actually do lower sperm count would be excessive heat. So men who spend lots and lots of time in hot tubs, saunas, steam rooms. The testes are external to the body, whereas for women, our ovaries are inside our pelvis, so they're protected by our body, and so they're not as sensitive to temperature. But because the testicles are external to the body, heat is one of the biggest culprits on affecting sperm. So spending lots of time, especially as we're entering into the winter months, can affect the sperm. It will decrease sperm count. We also know that tobacco use and marijuana use also decreases sperm count. So more and more states are legalizing the use of marijuana, including the state of Colorado. So it's a common question that I get with patients that come to see me in Colorado. But there is data that sperm count and the movement or the motility can be decreased with marijuana use. That includes either smoking it, chewables, edibles, all of that.
Interesting.
We do know that tobaccos also can decrease sperm count, whether that's chewing tobacco or cigarette tobacco use. So those are the biggest culprits that do affect sperm count. Now, another big thing is that I do have men, especially cancer survivors, who've gone through treatment and perhaps they are feeling lethargic, low energy. They go and see their primary care provider, or they might even see a male urologist that specializes in on the male side, and they are offered testosterone. So testosterone injections can be a great remedy for low testosterone. But one thing to keep in mind is that when men get external sources of testosterone, their testicle will no longer produce that testosterone, and therefore they become azoospermic. They stop. So that's one of the myths that I do want to debunk today, that being on testosterone treatments, just to give you a little bit of a boost, will have an adverse impact on fertility, and it will cause the sperm count to be zero. The testes, the cells in the testes that are responsible for sperm production are acutely sensitive to local testosterone production. And if your body is sensing that you're getting testosterone through an injection or a pellet or some other source, it's going to tell the testes, those cells that make testosterone, hey, I got this. I don't need to make it. And if the testes are not making testosterone, then the sperm cells in the testicle will say, I have no source of testosterone, so I can't make sperm. If a man stops their testosterone treatment, in about 4 months, we would see a recovery in their sperm production. So it can be reversible.
Interesting. Are there any other somebody was wondering about Mountain Dew or cycling.
That. Yeah, I know nothing about Mountain Dew, so I wonder what's online or on the blog about
well,
that.
Come on, it's Dr. Google.
Yeah, that's right. So I'm not aware of any correlation between Mountain Dew or any other type of beverage, in terms of caffeinated beverage being associated with low sperm count.
What about cycling? I know that I've heard that also. biking
So
and things?
yeah, so for the casual cycler, if you do leisurely cycling, those are not patients that I'm worried about. More and more of us, especially with COVID-19, are using home gyms, which
Right.
might include a stationary bike.
Right.
If you're getting a normal exercise on the bike, I'm not worried about that. Now, I do take care of some extreme athletes. So I take care of, professional cyclists.
Right.
And these are folks that are cycling 200 miles a week easily.
Yeah.
We might do
Right.
200 miles on a weekend. Those are the men where I am a little bit more concerned. And it's not because of the cycling per se, but because the testes are external to the body. When men are cycling, that's putting a lot of pressure with the bike seat on their testes.
Interesting.
There. And then if they're cycling outdoors and it's warm or even in the summer, then it's also a concern because of the heat.
Yeah. Yeah, that makes sense. Any other myths that you've heard of that are indeed myths and are not true?
Gosh, let's see. I'll have to kind of think about that there. One other myth that we can dispel is about caffeine use. So,
Oh.
Excessive caffeine use has not been associated with infertility, either on the male or the female side.
Hmm.
And in fact, even American College of Obstetrics and Gynecology does not state that caffeine has to be eliminated for women who are either trying to achieve a pregnancy or even in pregnancy. So what our professional organizations advise is that up to 150 milligrams of caffeine. So an 8-ounce serving of black coffee has about 80 milligrams of caffeine.
Okay.
Now, if you're getting a supersized caffeine beverage, that's a whole different story. But normal size 1 or 2 cups of coffee, or I usually tell patients 1 to 2 8-ounce servings of caffeine is still considered to be safe as women are trying to get pregnant, even in pregnancy. So that's one of the myths that we can bust.
Debunk. Perfect. All right. If you're just joining us, we are talking with Dr. Kondapalli about fertility and cancer. And if you have any questions, please go ahead and put them in the comments. And I see we just got one more.
Yeah.
How long would it take for sperm to regenerate for someone who smokes marijuana regularly?
Yeah. So a good timeline to think about is usually about 4 months. And that's for any type of sort of toxic exposure on the testes, whether that be chemotherapy, whether that's radiation, excessive tobacco use or marijuana, or even testosterone, like testosterone injections. A good time frame would be we would discontinue the sort of exposure, and then I would expect in about 4 months for the sperm stem cells to regenerate the sperm supply, and it would be present in an ejaculate. So 4 months time frame would be a good interval for any type of exposure like that.
Okay. And I'm curious, just because we haven't mentioned it, does alcohol have any kind of impact on it?
So there is some data, but now it's really with excessive alcohol use.
Right.
There is data that that excessive alcohol use, and that can be, defined so differently.
Right.
But in general, what we think about is over 20 alcoholic beverages a week. We do see some data that sperm count and the movement of the sperm can be impacted with that.
Okay. Yeah. Okay. And then we have another question. How is your clinic operating during doing fertility testing during COVID?
That's a great question. So, at CCRM, we are taking extra precautions so that we can keep things as safe as possible for patients, safe for our staff. So the things that we have implemented in our practice is, one, almost all of our patient visits are done with telehealth. So we have converted everything to video conferencing with patients. And patients have been pretty receptive to that because they are able to do their consultation in the comfort of their home or or their work environment. They don't have to travel into our office.
Yeah.
And for something, so for my field of medicine, a lot of the initial consultation can just be done by talking to a person.
Yeah.
An exam is not necessary at that initial visit. And what we would do is just sort of outline what our next steps would be and what testing we would want to have done to get a fertility assessment. And then when a patient comes into our office, we're requiring masks to be worn when they enter the office. We are having social distancing in our practice so that only patients that have an appointment at that time are permitted to come into the office. We're also limiting the number of people that are in the office at any given time. We check temperature, do a questionnaire to assess for any symptoms or exposures to COVID-19. We are spacing out our appointments for blood work and ultrasound, sperm testing. That allows my staff plenty of time to clean the equipment, disinfect the rooms in between patients. And then for those patients that are pursuing fertility treatment, we're actually testing them for COVID-19. So we are doing COVID-19 PCR, which is looking for active infection before we proceed with a fertility treatment. So we're taking some extra precautions because this is the time that we live in.
Definitely. Another question. Is there a time frame of unprotected sex without getting pregnant that would be an indicator of needing fertility preservation help?
Yeah.
And so she said that she has heard 1 year. And is there any data behind that?
Yes. So there is data behind that in sort of a general population. And it goes back to one of the initial things that I talked about, which is the age of the eggs.
Right.
So for women who are under the age of 35, a reasonable time frame is 12 months of unprotected intercourse. And if she hasn't achieved a natural pregnancy, then we would do fertility testing.
Okay.
For a woman who is 35 years and older, then it is waiting 6 months. And that is because as we get older, our eggs are aged. We want to be a little bit more proactive in assessing fertility, seeing if there's a way that some fertility treatments might be helpful for a patient. Now, I do modify that for cancer survivors. Now, I think it depends on how old a woman is now as she's thinking about starting a family. And because cancer patients may have been exposed to chemotherapy, radiation, especially if your oncologist has told you that there's some fertility impact, then I think a 4 to 6 time frame across the board is very, very reasonable. Even for younger women, to at least do some initial testing to see if there is a decline in their egg count that is much faster than what would be expected for her age, and then we would think about maybe some fertility treatments.
Excellent. Thank you for the questions, everyone who is posting them. We really appreciate it. There was one last question related to the sperm count. I don't want to forget. Vitamins. Is there any kind of vitamin that can help increase your sperm count?
Great question. So unfortunately, we don't know of any vitamins that are available over the counter that really improve sperm count. There are some medications. So these are prescription strength medications, and a male fertility specialist like a urologist would be the appropriate person that could prescribe that medication. So there are some medicines that can be administered. Those medicines to improve sperm count after we've done all the lifestyle modifications, tobacco, marijuana, excessive heat, excessive bike riding. There are some oral medications that can be given. These are daily medications. There are some injections. They're not testosterone injections, but there are some other hormones that men can take to give them a boost on their sperm count. So yes. Now, if it's an issue with the shape of the sperm or the quality of the sperm, there are some over-the-counter vitamin supplements that can be helpful. CoQ10 is a great sort of natural antioxidant that can be helpful. Vitamin E, zinc. So there are some vitamin supplements that can be helpful to help with the quality or the shape of the sperm. Our website, so if you find CCRMIVF.com, there is an area for male fertility, and you might find some of those sources on some of the other vitamins. The same is true for women. So there are some vitamin supplements that can, have some subtle improvements on the health of our eggs. So CoQ10, high doses of fish oil can be helpful. Vitamin E are some of the top ones there.
And in both cases, the goal or the result being hopefully a higher chance of actually conceiving. Like if the quality of the sperm and the egg is better than the higher quality.
Correct.
Right. Are there financial programs, going back to the financial aspect, are there programs or resources that can help where maybe, if the insurance pays for part of it, are there programs that are available to help?
There are, and yeah, that's a great question. And a question that oftentimes I get asked. There are some resources, particularly for cancer patients at the time of diagnosis. So most of the resources are available for cancer patients before they go through treatment.
Right.
That is also the best time for fertility preservation. Before a patient has started any type of cancer treatment is the best time to either freeze eggs, freeze embryos, freeze sperm, because the tissue that I obtain has never been exposed to chemotherapy.
Right.
So we're less concerned about the impact of that cancer treatment on what I freeze. So there are resources at the time of diagnosis. A variety of different resources are available. For example, and then there may be some resources that are specific to the fertility clinic where you seek treatment. So for example, in our practice, we do provide some discounts to cancer patients at the time of their diagnosis if they're pursuing sperm freezing, if they want to do egg freezing or embryo freezing. And then there are some other programs through pharmaceutical companies where some of the medications for fertility preservation may be obtained through those programs. There are less resources that are available for cancer survivors, unfortunately. I think the focus has really been at the time of diagnosis, and there are limited resources on the survivorship side. But this is another place where, being, finding a good fertility specialist that can be an advocate for you, or finding someone like myself who has a lot of experience in the oncofertility space and kind of knows, what resources are available can be really helpful for you.
Yeah, I was wondering, I mean, because depending on the kind of cancer, I would imagine that an oncologist that deals with, for example, testicular cancer or women's reproductive cancer might have some more understanding of what's out there, but someone who's dealing with lung cancer or anything else, maybe not. So would you recommend, rather than ask the oncologist, seek out a fertility specialist?
Correct.
Yeah.
Correct. So I think that if you're interested in gaining more information, because again, I'm sure your oncologist is so focused on the type of cancer, what's the most effective treatment. Their goal is to get you into the survivorship period, and they may not know the fertility side, just like I don't know the oncology side as well. So asking your oncologist if they haven't brought it up to you already, say, hey, I'm really interested in a fertility consultation, and then they will be able to, refer you to the right person. Now, one of the unique things about our practice at CCRM in Colorado is that we see a lot of patients that don't live in Colorado. So even as part of my practice, I see a lot of patients that live outside of Colorado or even live outside the United States. And as I take care of them just for their fertility needs. And the same is true for cancer patients. I do get consults for patients that don't live in Colorado. And if they decide to pursue treatment, I've had patients that have traveled to the Denver area to do treatment with me. And since now everything is converted to telehealth, it's just I do telehealth visits for international patients just as easily as I do telehealth visits for patients that live 2 blocks away.
Right.
So if patients are interested, one, talk to your oncologist and say, hey, is there a fertility specialist that I can talk to about these things? Or you can, contact someone like myself who has expertise in this area.
Excellent. Excellent. So if you're watching and you don't live in the Denver area, you heard it here.
Yeah.
You can still reach out. That's excellent. We do have another question. Let's see. Are there any organizations out there that assist with preservation or storage?
Yes. And so I think the fertility clinic that you work with may have some resources for you. So in our practice, we do have some financial help for the fertility preservation technique and the storage. When we have patients that freeze sperm with us, we also work with a long-term storage facility to provide a discounted price to men who want to have their sperm frozen for a prolonged period of time. So I think there are some organizations and some other places to find some financial assistance, and maybe starting with your fertility team would be a good starting point.
Excellent. Thank you. Thank you again for the questions, everyone. These are awesome. All right. I think here's another one. Is your office offering discounts for consults to cancer survivors?
Yeah, so those are questions. I don't really focus much on the financial side of the process. I have fantastic folks in my practice that do all of the financial consults, and many times for cancer patients and survivors, they will all preemptively do a financial consult, see what insurance coverage, what the cost would be even before a patient comes to see me for their initial consultation. So because I have so much experience with cancer patients and we understand the acuity of their care, we have a whole triage system within our practice. So if we have a cancer patient who wants to have a consultation, I see them within 24 or 48 hours. And it does start a chain reaction in our practice where we have a very streamlined process for them to get scheduled with me. And that will sort of start the financial conversation with the folks in my practice that really are experts on that. I try to focus on the medical side because I have really good people on the financial side that can help with that. So they'll be able to contact the person even before they come in for that consultation.
Awesome. Okay. All right. I'm wondering about proactive steps. What are proactive steps that someone could take to give themselves the best shot at having a positive fertility outcome?
Yes. So a couple of things that I would advise would be, we know that lifestyle is such a huge factor, just in overall health, but we also know that for fertility. So, having a healthy diet, having a healthy BMI, especially for women, because we know that weight in pregnancy and what your starting BMI is can have some impacts on having a safe pregnancy. So having a healthy weight, having a healthy lifestyle. I'm always a proponent of exercise and sort of mental wellness. The other things that I would advise folks is to make sure that, your annual exam is up to date. You've had a head-to-toe exam in the last year. If I have women who are a little bit older, if they're due for a mammogram, making sure that all of the routine wellness things are taken care of as we're thinking about starting a family. For women who are planning on starting a family, being on a prenatal vitamin, folic acid is in a prenatal vitamin, and that's important to prevent neural tube defects or issues with the way that the baby's neural spine forms. Also, women should be on DHA, which is omega-3 or fish oil, and being on 200 milligrams of DHA is important for the fetal brain to develop. And then for cancer survivors, even if you don't necessarily go down the path of fertility treatment, talking to your gynecologist about, hey, maybe it's worthwhile for me to see a maternal fetal medicine doctor, get that preconception counseling, because certain types of cancer treatments, whether it's chemotherapy or radiation, can impart pregnancy complications. So you want to know that ahead of time so that hey, I got X chemotherapy. That means that one of the long-term effects might be something on my heart. And we know in pregnancy that a woman's blood volume increases by 50% because so much blood is getting pumped through the placenta. And in order to, have the baby grow appropriately, and in order for a woman to get that blood to the placenta, she has to have a really healthy heart. So if I know, gosh, I got this chemotherapy before, that means that I might have some issues in pregnancy. Does that mean that I need to have extra monitoring in pregnancy? And a maternal fetal medicine doctor can lay out a surveillance plan in pregnancy, so that going into even sort of the preconception period, we're equipping patients with the best information to put them in the best position of being successful.
Interesting. So beyond even having your eggs frozen or your sperm, there could be other complications that result from radiation, and so that's kind of the second part of it.
That's right, exactly. And knowing that ahead of time and having an active plan, I think can also give people peace of mind, knowing that, hey, you might not need a fertility specialist like myself. Even for folks that have gone through fertility preservation, I do tell them this does not preclude you from achieving a natural pregnancy. We have this as a potential for pregnancy in the future if you need to use them. And having sort of a pregnancy plan in mind about, what are my unique risks in pregnancy, and, how are my providers going to put me in the best position of having a successful outcome?
Yeah. Excellent. Well, I usually like to close this Beyond Cancer series by giving the person I'm interviewing a chance to share anything that I haven't asked about. If there's a topic that I haven't brought up, I figure we kind of close with that. If there's a tip, a question that you're often asked that we haven't asked here, advice.
Thank you, Gail, for that question. I think as a final, my final comments would be, going through this process, whether it's a cancer survivor who's now facing infertility, or even I take care of infertile patients that have no medical problems too. The reality is that infertility is very common, and you're not alone. 1 out of 8 people are facing infertility or difficulty getting pregnant. A lot of people are seeking fertility assessments and maybe even fertility treatments, and doing your homework and finding out, what's going to be a good fit for you in terms of who's the best provider that's going to walk with me along this journey. What's the right practice for me? What's their success? How am I going to have a successful outcome? And what other, support services and resources are available in that particular practice? One of the things that I feel so fortunate about in my work at CCRM is that we have so much support services. So I have a whole team of genetic counselors. So if I have some cancer patients that have a genetic predisposition to their cancer, they might be interested in doing genetic screening of embryos. That's known as pre-implantation genetic diagnosis. That way we can identify which embryos might have the same cancer gene, and then we can preferentially transfer unaffected embryos. I have a whole team of genetic counselors that kind of shepherd patients through that. But we also understand that it's an emotional process, and we have a tremendous amount of resources. I have licensed counselors in our practice that specialize in fertility issues and pregnancy loss, and they are available to patients as they go through the entire process, from the moment that patients come into the office to the moment that they graduate from me. So finding a place that's going to be a good, a good fit for you, I think is really helpful.
Excellent. Thank you so much for taking the time. This has been super informative for me, and I can tell from the questions and from those who are watching that it has been super informative.
Well, it was such an honor to be with you, Gail, and with everybody today. So thank you for inviting me to participate this afternoon.
Well, great. So if you are watching and you want more information, there's going to be a slide that comes up after that has Dr. Kondapalli's information and how you can contact her office and things like that. And you can always reach out to Epic also, and we can connect you that way as well. So thank you everyone for attending tonight. We'll be here again in 2 weeks. And Dr. Kondapalli, thank you so much.
Thank
We
you
really
so much,
appreciate it.
Gail. Everyone be well.
Have a good night.
Thank you.
Epic Experience was founded after my oldest son, Michael, was diagnosed with testicular cancer in 2007. I wanted to offer up hope to other cancer survivors so people know they're not alone, so that they know they can get out and start living again. It just may look different than how it did before they had cancer.
Epic Experience is unique in the fact that we really pride ourselves on trying to take anyone and everyone that we can. Doesn't matter when you were diagnosed. If you've been diagnosed 5 years out, 10 years out, 20 years out, we don't put a timeline on it. We say that, you know what, if you've had cancer come into your life, we have a place for you.
Epic Experience. One word, it's epic. You have a chance to come up here and do some things that you've never probably done before.
This camp has taught me, like, why are you afraid? Like, what's stopping you? I got out on the water in the pond here, and I'm like, I haven't done a headstand in a long time. And it's really difficult to do it on water. And I'm like, what am I afraid of?
At camp, it's about healing your soul and your spirit and living beyond that cancer diagnosis, having fun, being with people that understand, and really just embracing everything that life has to offer you.
They just said you were going to go to a camp, and I didn't even know where it was going to be. I got hauled up the mountain and got to play in the snow, and the thing that happened is I rediscovered joy, found myself again. Favorite memories from camp? Running down the hill in snowshoes. It's something I never really considered before.
I got on a sled today, and I'm going to be honest, I mean, I've beat cancer, but I was still nervous to get on a sled.
Well, kayaking is individual. You're all alone in your boat, and it's you versus the elements and how strong you are and getting through the challenges that are coming up, whether they're rapids or something in the water in the way. And with cancer, it's you versus your diagnosis.
Epic Experience is about empowering adult cancer survivors and thrivers beyond their cancer diagnosis. It's about giving them a community in which they feel that they have people they can connect with, that understand them, and walk their shoes to really know, hey, you know what, I'm not alone, and I have people with me, and it's so important for them to feel that connection.
Things that I used to worry about don't worry me as much anymore. Family is critically important. Friends and experiences is what life is about.
Well, I didn't think I needed this week, but I needed it more than I knew. I needed to just play in the snow. I needed to laugh until my sides hurt. I needed to connect with people, even though I didn't think I did. I needed to find out that I'm not alone in things I think I'm alone in.
So here at the 7W Ranch, not only are the activities that we do for the week amazing, but just the beautiful scenery around alone makes it just so incredible.
I was feeling a bit lost and unsure how to cope with life after cancer. I feel like Epic Experience brought me closer to who I used to be and who I want to be in the future.
Want me to cry when I talk about 7W? It's magic. You say. It's special.
If you are debating on coming on this trip, just do it. Don't hesitate. I hesitated. I waited till the last minute, and I am so grateful that I came here.
This has been life-changing. This week has absolutely changed my life in ways that I couldn't have even imagined that it would.
Epic Experience is the right name for this experience. Trust, go for it.
Why can't you experience this? It's something that they've already been through, cancer treatments, whatever the therapy is, and this is another way to heal.
If you want to really check back in with yourself and find out where your inner person is and where your soul survives, come to a camp and just let it be.
Don't think about it. Don't wonder, should I? Just do it. Sign up for camp, and it'll be an amazing experience full of a lifetime of memories.